Good afternoon, everybody. It really is a pleasure to be speaking to everybody today. On behalf of Katherine, myself, and the other co-authors of the manuscript, we just want to say that we're humbled by your interest in the research, and we're really excited to share our learning. So thank you for joining today's webinar. As Anna mentioned, it's titled Infection Prevention Control Infractions in Ontario Personal Service Settings. What were the common issues in 2018 and what can we do differently? So I'm going to transition the slides here and hopefully that works. All right. So over the next 40 minutes or so, we'll be providing a bit of background and context about PSS in Ontario by describing the current landscape. But also some of the reason for the background is just to provide some context for some of the key data that we used in our study, just appreciating that the attendees on the call are from all across the country. So I'll be providing the background, and then from there, I'll hand it over to Katherine, where we'll move into describing the manuscript, starting with the objectives, then moving into the methods, results, conclusions, and recommendations. And then to close with the discussion, we'll have some kind of discuss some of the study's challenges and then open it up for question and answers. So hopefully that sounds like a plan to everyone. And then in addition to our slides, to help make the presentation a bit more interactive, we also have a few polls throughout. So I'll actually ask for the first poll question to be launched right now. If that's okay, Anna. So the poll question is asking, which of the following are considered to be personal service settings or personal service establishments in your province, region, territory? And you can please select any and all that apply. So we'll give it a few moments. So it looks like the responses are coming in nicely. Thank you very much. We're kind of slowing down. So yeah, so for those on the line with experience in the field of PSS, you'll know that it's an ever-evolving sector with kind of new, weird, and wonderful services and devices being introduced all the time. And you'd argue that it has equally as much innovation or more innovation as even the tech sector might have. So it's really hard to know which services fall under the guise of PSS sometimes and which may be served best in other areas. So looking at the results here, a fair amount of commonality in terms of the traditional ones like barbering and tattooing, piercing, and manis and petties, and microdermabrasion even. But you might have some interesting ones like sensory deprivation, which may not kind of fit the traditional definition. It may cross other public health fields, like perhaps it could be considered a pool or a spa or a PSS, depending on how you define things. So just a little poll just to kind of get a sense and to kind of tee up kind of what are PSS. So thank you for that. And we actually have another poll question just to start off. And so the question is, which organization best represents you? And so we'll have that poll pulled up too, please.
Just as everybody is filling out their polls, we've got a note here to, could please, the audience, please turn off their cameras for now. Thanks.
Great. Again, it looks like the poll question. Thank you for that, Anna. Looks like the poll questions are slowing down too. And again, it looks like a good spread across local public health units, agencies, as well as government in terms of provincial, territorial, and federal. So what we're hoping by asking that is hopefully you're able to take some of the results that we have in our study and see how it may apply and may kind of allow you to take some of the information back to your respective programs and see if you can incorporate some of the findings that we have. So thank you for that. So we can close the poll. I'll move on to the next slide. So as mentioned, personal service settings are a growing industry, and in Ontario, this encompasses a whole range of services. And by definition, these are ones where there is a risk of exposure to blood and bodily fluids. So it includes the ones that we've mentioned in our poll, hairdressing, barbering, aesthetics, all the way to invasive procedures like tattooing, piercing, and other body modification. So as you know, or have likely kind of experienced, the prevalence of people who have received invasive services like tattoos and piercings is quite high, and in fact is growing. So just for interest, there's a study in Ontario that surveyed individuals between the age of 16 and 35, and what they found was about 48% had at least one tattoo, 65% had piercings, in addition or excluding earlobe piercings, and 26% of the respondents had neither, but half of that group who had neither intended on obtaining a tattoo or a piercing in the near future. So the invasive services are quite prevalent and in fact growing in popularity. Other services that are growing in popularity too include holistic services such as colon hydrotherapy, sensory deprivation, as we mentioned, and a whole host of others claiming to have a wide variety of health benefits. And kind of as we were teasing at the beginning, it kind of challenges and pushes the boundary of what defines a PSS. So you may see variety across the country depending on how PSS is defined in your region. So again, to provide some context from the Ontario picture, we thought we would just cover a little bit of the legislative framework. And so actually the legislative framework has become a bit more robust in terms of PSS in the last few years. So I'll walk through this flow diagram a little bit just to, again, provide context to some of the reasons as to how and why the data is available for the study project, for the study that we endeavored upon. So starting at the top, so the overarching act is the Health Protection and Promotion Act, or it's also known as the HPPA. This essentially governs the work of the 34 health units in Ontario. Within the HPPA, health inspectors have the ability to lay what's called a Section 13 order in order to address or correct what a health inspector may deem a health hazard. So historically, the onus of such proof within a PSS setting was quite challenging in that regard. So enforcement efforts were fairly limited as a result. But in 2018, however, the HPPA was updated and a PSS regulation was enacted in Ontario. And so this obviously provides a lot more detail. So the regulation, the PSS regulation, it sets out the minimum expectations for operators with respect to things like setting requirements, the need for disposal of sharps, cleaning and disinfection and sterilization requirements of reusable equipment, the need for record keeping in terms of invasive services, as well as disinfection logs, for example. The regs also specify or actually specifically prohibit certain services such as ear canneling or coning, as well as prohibit personal services that involve aquatic species like fish pedicures. So that's all within the regulation, but of note, the HPPA, during its update, it also included certain prohibitions too in terms of PSS, specifically scleral tattooing. So that's the tattooing of the whites of the eye, as well as implantation of eye jewelry under the conjunctiva. So those are now prohibited services as well. So again, speaking specifically to PSS. And so then continuing down the flow diagram here, in addition to the HPPA and the PSS regulations now, the Ontario Public Health Standards are a tool as well. So these standards set out those minimum expectations for the mandatory programs and services that all health units are to provide. And so under the infectious and communicable disease prevention and control program standard, there are several protocols. So these include the infection prevention and control protocol, known as the IPAC protocol. There's an IPAC complaint protocol and an IPAC disclosure protocol, all of which have implications for personal service settings as well. So quickly to review those. So the IPAC protocol, it sets out the expectations for health units to inspect PSS to ensure compliance with the regulations and the PSS guideline. And it requires that inspections should incorporate a risk assessment, taking into account the service invasiveness, risk of blood and body fluid exposure, the degree of adherence to IPAC best practices, including those relevant to cleaning and disinfection, sterilization, for example. And then the other protocol, so the IPAC complaint protocol, this one sets out direction for health units to take regarding the investigation, the management, as well as the reporting of IPAC complaints, including those that may involve a personal service setting. There's also the disclosure protocol, and this provides direction to the health units about online disclosure of all IPAC routine inspections, IPAC complaints that may be received, as well as IPAC lapse investigations, again, of which could involve personal service settings as well. And then right at the bottom of the flow diagram, bottom right there, in addition to all these protocols, there are the PSS guidelines, and these are intended to assist the health units in implementing and interpreting the regulations and all the various protocols just mentioned. And then over on the left-hand side of the screen in the green box, there's another resource that supports PSS in Ontario, and this is the Guide to Infection Prevention and Control in Personal Service Settings document. And this too was released in November 2018. So this guide was written by Public Health Ontario, and it's intended to provide health units and inspectors with IPAC best practices for PSS. And this is based on the best available evidence at the time of writing. So again, laying out this legislative context paints the picture as to some of the data that was available to us for our study. So pulling all this together in terms of the Act, the regulations, the standard, protocols, guidelines, best practice documents, this is what it looks like in practice in Ontario in terms of inspections and inspection frequency. So public health units, they're required to inspect all personal service settings at least once a year, ensuring compliance with the regulations, the guidelines, and the best practices that we've just mentioned. In addition to those once a year, additional inspections can occur, and those would be in response to complaints, could be for re-inspections, or requests for service such as a pre-operational inspection, or if a existing premises changes a service or wants to add another service, those can be standalone inspections as well. So during any of these inspections, if there's non-compliance, it actually may be deemed an IPAC lapse if there, again, is that risk of potential infectious disease transmission as determined by the health inspector. And if this is the case, a thorough investigation is then undertaken, incorporating that risk assessment, specifically for bloodborne infections, and could result in potential patient notification or client notification. And then finally, as we described with some of those protocols, the health units must then publicly disclose the results of these inspections or any potential IPAC lapses on their website. So that's how it all kind of comes together, I guess. So as I mentioned, the PSS landscape in Ontario has changed fairly recently, since 2018, essentially, with the regulations and the release of this updated best practice document. So this was important in terms of timing for our study period. So we actually chose inspection results that took place prior to the release of this revised document. And later, Katherine will touch on and expand a little bit more of the relevancy of that timing as it relates to the potential for a follow-up study with kind of a pre and post design But for interest, some of the key differences between the previous version, which is in effect during our study period, and then the current version that's being used today. One of the key ones is there's a change of author. It went from a Ministry of Health document to a Public Health Ontario. This actually better matches the respective mandates of the two organizations, where the ministry is responsible for policy, and then Public Health Ontario is responsible for science and technical support. And then a key difference in terms of the content is the foundation was moved from more of a service-specific document to a principles-based one. And this was key due, again, to the fact that services and equipment are ever-changing. So rooting the guide in principles allows it to be a bit more timeless going forward. So again, in Ontario, common personal services that are offered are hairdressing, barbering, aesthetic service. These include things like waxing, manis and pedis, microblading, micropigmentation, as well as some of the other ones that we've mentioned in terms of tattooing and piercing. Obviously, the degree of invasiveness and exposure to blood and body fluids varies across the spectrum of these services and influences the risk of potential infection as a result. And it's due to this and the fact that there's a dearth of literature regarding the risk associated with specific services that we endeavored to learn a bit more by conducting the study that we've done. So at this point, I'm actually going to ask Anna to pull up our next poll, please. So this question asks, which services would you consider to be associated with the greatest risk of infection transmission? That's great. Thank you for the timely responses to that, and seeing the kind of responses across the board, with tattoo and piercing kind of being the front runners. If you did say that, then I think you could argue that you are correct in terms of that, as these are deliberately invasive services, and they've been historically and kind of theoretically, due to their invasive nature, been considered to be associated with the highest risk of infection, particularly due to bloodborne infections. Kind of as a result of this, some health units have either in the past or currently have implemented inspection frequencies that are kind of related to that relative risk of infection and the invasiveness of services. So they would inspect tattoo and piercing establishments at a frequency of 3 times a year. They might do nail services twice a year, and then those offering hair or barbering once, or waxing even once a year, for example. But I think as we describe and as the research is showing, there may be some room to kind of consider where the risks are going forward. So a bit of a teaser in terms of the results that we're looking for. So thank you for that. If I could ask Anna to pull up the next poll, please. And so as we kind of teased in terms of different inspection frequencies, we're just wondering, how often does your public health unit or authority routinely inspect PSS? That's great. Thank you for those results. So that's really interesting responses too, to see that the majority, 51%, are once a year, but there is variety. So there could be kind of a risk stratification process as it varies by premise type. So that might be something worth exploring and chatting about towards the end of the presentation today too. And then again, by complaint only, that is something worth exploring as well. So thank you for that. So as you're likely well familiar, PSS use a wide range of instruments and equipment, and there's always new products or variations of products coming available. But these really can be broadly classified into one of two categories. So those are instruments and equipment that are able to be reused after appropriate reprocessing in one category, and then those that are single use, i.e. not able to withstand reprocessing and are to be discarded after use. So there's a lot of instruments listed on the slide here, and this is not meant to be an exclusive or an exhaustive list, but they're just some of the common ones found in PSS. But before we get into our study results again, we just want to dive into a little bit further information about reprocessing and kind of what it looks like in PSS in Ontario, looking at this type of equipment. So as you may be familiar, Spaulding's classification describes the level of reprocessing to be used for medical equipment or instruments, and this is based on their intended or the actual use. So while this classification system is intended for healthcare, it's been broadly adapted and refined for the use in PSS as well. And this too is a way of determining the appropriate level of disinfection of equipment. And again, it is a source of kind of some of the information that we find within our study. So whether or not a personal service is invasive, I think you can argue that each service has an inherent infection risk if appropriate IPAC practices are not followed. So as you are likely familiar, there is a lack of formal surveillance of infections related to PSS, and this makes it difficult to really provide accurate information on the actual risk of infection from these procedures. And there's a host of reasons as to why that is the case. But so with that in mind, with not having a robust surveillance system, where do the issues lie? So from my experience and many that you talk to across the country, anecdotally, the issues don't lie with the high-risk practices of tattooing and piercing, which we kind of previously identified in that poll, but it's often in the PSS offering the aesthetic. So you could kind of see that line of thinking as well in some of the poll answers that we saw, identifying manis and petties as being kind of higher risk. So while there's a dearth of high quality evidence, there is some previous research that is available that indicates that PSS owners and operators, that they actually report reusing single-use items. They also report reprocessing reusable equipment only once, and that would be at the end of the day. So this aligns with that anecdotal experience from the field as it highlights a knowledge gap regarding the infection transmission amongst some of the PSS owners and operators. So for interest included in the reference list, there's some examples of research that support some of that anecdotal observation from the field. But that's also the hope that we have in terms of our study as well. So in addition to observations from the field and that anecdotal experience, there have been documented cases of infections associated with PSS, and those are found in the literature, specifically around transmission of hepatitis B, hepatitis C, and mycobacterial infections. And this would be as a result of kind of some of that other findings, which is it's as a result of improperly reprocessed equipment or the reuse of single-use equipment. So of interest, a recent Public Health Ontario hepatitis C surveillance report identified that in 2018, among over 4,500 hepatitis C cases, where they reported at least one risk factor, 33% of those newly acquired cases identified PSS as a potential risk factor. Now, the association between visiting a PSS and having hepatitis C doesn't imply causation by any stretch, and it may just simply be reflective of the frequency that the average person in a population visits one or more PSS. But on the other hand, it does merit further consideration that during case follow-up, whether additional questions can be asked about previous PSS exposures, which may support potential acquisition of infections, such as have you ever sustained a cut during a service, for example, as this wouldn't necessarily be considered one of the more likely risk factors for Hep C, but maybe be underreported. So just food for thought anyways. And then, as mentioned, if there are instances where a health unit feels that non-compliance issues at a PSS may result in potential infection transmission, then a lapse, IPAC lapse may be declared. And there have been some instances of IPAC lapses associated with PSS in the media in Ontario. And they actually have typically resulted in a need for public notification to ensure that customers and clients of implicated premise are aware of the need to pursue testing for bloodborne pathogens. So if a client record are deemed detailed enough at the premises according to the health unit, they may complete a targeted notification process. But if it's not, the health unit may decide to trigger a broader communication approach using a media release. And again, it's lapses like this would be disclosed on the health unit's website. And we've mentioned a few times now too that one of the challenges with the field of PSS is that dearth of high quality evidence and research, which is why we found Public Health Agency of Canada's 2019 publication, which is found in the Canadian Communicable Disease Report, the CCDR. It was quite timely as it further affirmed the need for PSS related research. So the CCDR put out a call of action in a sense, stating that there's a paucity of high quality evidence to support guidance, and findings reveal that the need for further investigation and enhanced awareness of public health risks associated with personal services. They also mentioned that Canadian studies on infection prevention in personal service settings is recommended to provide information on the transmission pathways and risk of infections, and allow for assessment of burden of illness related to personal service settings in Canada. So again, quite timely given the research project that we were undertaking. So with that, I will now hand it over to Katherine.
Thanks, Dave. So I'm going to move fairly quickly through this because we want to make sure we leave lots of time for questions. But basically putting all of this together, why did we do this study? Well, we were interested to understand how common are the various infractions and PSSs in Ontario, and do they differ by premise type? And if so, what does that look like? We were interested to see what proportion of publicly reported IPAC lapses, so those that meet that threshold of potential infectious disease transmission, actually took place in premises that are PSS as per our provincial categorization. And then to look and see whether the infractions that were identified during those IPAC lapse investigations were similar to or different from those that were identified during routine compliance inspections. So what does that look like? Is there overlap there, or are we seeing two different kind of streams of compliance issues? So how did we do this? So we obtained data from 3 public health units in Ontario, and these were selected based on the public online availability of their data. Some health units make their data publicly available via an online data repository, so anyone can go in and download the data and work with it, which is awesome. As well as based on their geographic variability. So we did end up choosing 3 that were a mix of urban and rural public health units, and these ranged in population size from about 450,000 residents to almost 3 million. So fairly robust geographic area covered there, and about a third of the province with respect to a tenth of the number of health units in the province. So the data that we obtained included the premise name, the dates of inspection, whether it was a compliance or other type of inspection. So that could be a complaint, a reinspection, or a demand type inspection. The service categorization of the premise as per the health unit categorization, and then the inspection findings. So whether each individual inspection item was categorized as in compliance, not in compliance, corrected during inspection, not applicable, not observed, for example. And then the IPAC lapse data, as Dave mentioned, public health units make their lapse data publicly available online, and it's online for 2 years. Unfortunately, there is no central data repository that's publicly available. So we did have to go website by website and manually combine and collate all of that data for those 35 public health units. So the data that we got there was, again, the name of the premise, the date, the trigger, sometimes for the lapse, whether it was a complaint or it was something that was detected through other mechanisms, which could have been during a routine compliance inspection. So in some instances, the same premise appeared in both of our data sets. And then the inspection findings, so what the actual infractions were and the outcome. There were a few differences between health units in terms of how they categorize their premises. So for example, some considered barbering to be separate from hair and some considered those to be in one category. So to facilitate looking at the data across health units for both routine compliance inspections and IPAC lapses, we had to do a little bit of what we call card sorting. And we ultimately collapsed the premises into each of one of 3 premise types. So barbering or hair, aesthetics, and body modification. And if a premise was offering a service from one or more of those categories, so for example, if we had a premise that was offering makeup services as well as permanent makeup, we'd place them in the higher risk category. So in that instance, they would fall in the body modification category. And then we look to see, similarly, we looked at the inspection items. And so to combine these for analyses and facilitate comparisons, we card sorted again into 16 different thematic inspection areas. So this was necessary because although each health unit typically asks about the same outcome-based things, the questions are worded a little differently from health unit to health unit, and in some cases, again, might be combined. So 2 things are asked in the same question. So when we bucketed those looking at the original inspection reports for each health unit, we ended up with those 16 inspection areas that could be either in compliance or not in compliance. And then in terms of analyses, we looked for differences in infractions between premise types using Pearson's chi-squared test. And then we compared infractions between routine inspections and non-routine inspections and lapses. And then something that we also looked at that wasn't in our publication, but we'll share with you today, was the distribution of lapses was also examined by season to see if there was any seasonality with respect to these. So what did we find? So a lot of inspections. So over that 1-year period in 2018, just with those 3 public health units, there were a total of 5,386 inspections conducted across 4,483 PSSs. So making the assumption that only 1 inspection per premise was a routine annual compliance inspection, that meant that almost 17% of inspections were additional inspections. So that these were conducted in response to a complaint or request by an operator, for example, if they were moving or adding a new service, or to follow up on previously identified infractions on the last inspection. We did find a significant difference in premise type and whether or not they had 1 or more infractions identified on inspection. So roughly 10% of inspections of premises offering body modification had 1 or more infractions identified, compared to 16% of inspections in premises offering hair and barbering, and compared to 20%, so 1 in 5 inspections in premises offering aesthetics. So looking at how common different infractions were within each premise type, those that are presented here on the screen were the top 5 for each premise type, and the ones that are highlighted in a color were in the top 5 for 2 or more premise types. So for example, in green, a failure to reprocess reusable instruments after use, so not according to instrument classification, just to reprocess period after use, was the most commonly identified infraction across all premises combined. And this was identified in almost 8% of all inspections. And this was also the most common infraction in premises offering hair or barbering, as well as in those offering aesthetics, and was the 2nd most common in premises performing body modification. A failure to reprocess reusable instruments according to that appropriate instrument classification, so for example, per Spalding classifications, was a common infraction in premises offering aesthetics, as was failure to dispose of single-use items, which kind of supported what we'd heard anecdotally. So that was interesting. Looking at our lapses, again, this time we looked at the entire province, so all of the health unit data, not just those 3 that we looked at the routine inspections for. So it was interesting to us. We were expecting to see a fairer number in PSS, but we were not expecting to see that 43% of the lapses were actually in a PSS. So there were 121 IPAC lapses according to the disclosure pages, and 43% or 52 were in a PSS. And of those, 73% were reported to have taken place in a nail salon or spa, which was much higher than we'd anticipated. And actually, when we looked at the individual lapse reports posted by each health unit for all premises associated with the lapse, 6 of the lapses in one particular health unit, which accounted for almost 38% of their PSS lapses, were regarding a complaint regarding subsequent infections. So of those 6, 1 was following a haircut, 2 following a pedicure, and 3 following a manicure. And 2 of those following a manicure were specifically identified as being fungal nail infections, which was really interesting. We only had that level of detail for the one health unit. It would have been really interesting to know if that was similar across health units or what that looked like. And then similar to what we did when we looked at our routine compliance inspection data, when we looked at the common infractions in IPAC lapses, so this was just looking at those 44 premises offering aesthetics in which an IPAC's lapse was identified. These were similar to the infractions that we identified during routine compliance inspections. So here we've presented the top 10, and as you can see, the most common infraction was, again, a failure to reprocess reusable instruments after use. So again, not according to instrument classification, although that was on our top 10 at 9.1%, but just failure to reprocess period was number 2, with number 1 being a failure to discard of single-use items after use and not reuse these. But as you can see, looking at our top 10, these all generally relate to premise sanitation, appropriate storage and avoiding contamination of instruments, and then general reprocessing or appropriate use of reusable and single-use items, including the handling and use of disinfectants. So a fair degree of similarity there. One other aspect, as I mentioned, that we looked at that wasn't in our publication due to space constraints was the distribution of lapses by season. So interestingly, almost 60% of the lapses that were reported in PSSs occurred during the spring or summer. So for example, we categorized summer as June, July, and August and onward from there. And considering that over 70% of the lapses in PSSs occurred in premises offering aesthetics, maybe this isn't too surprising, because these are also the warmer weather months in Ontario, and those when people may be wearing open-toed sandals or other footwear, for example, and may be more likely to get their nails done. So potentially this is just reflective of the access and utilization of those services. So before we get into our interpretation of our findings, we had another poll for you, and we were wondering if you can think of any potential reasons why we might have identified more infractions in premises that we categorized as being aesthetics compared to other premise types. If you don't mind using the chat box, I think for this one, is that correct, Anna?
Sorry, yes. Please put your answers in the chat box if you can.
There are no wrong answers. We're just curious if you can think of any reasons why we might have identified more in these particular premises. And then we'll give you our potential reasons.
Oh, great. Yeah, we've got some answers here. More items to reprocess, less historically scrutinized, greater volume of services, less staff training. I could let you.
Okay, thank you. So some of the reasons that we came up with were, you might be thinking this might simply be due to there being more premises offering aesthetics. Maybe just the majority of premises are premises that offer aesthetics compared to other services. And if so, you may be partly correct, because in our study, we did consider this, and we found that premises offering aesthetics, according to our categorization system, accounted for about 47% of the premises in our study, and just over 49% of the inspections in our data set. However, when there were infractions found, there were significantly more in these premises compared to other premise types. That doesn't seem to fully account for it. So premises offering, sorry, I'm just going to close this. Premises offering aesthetics and nail salons in particular often use a broad range of instruments, many of which are inherently sharp, like nippers, clippers, scissors, and do have the potential to accidentally penetrate the skin. As we saw with the seasonality aspect, depending on the time of year, there might be minimal time between clients if it's a heavier volume time of year, which might result in poor or no reprocessing of instruments and particularly reusable items in between clients and reuse of single-use items. And single-use items might be cost prohibitive. So in some premises, there may be a temptation to reuse these to save money, particularly if the individual operator is responsible to provide these rather than these being provided by the premise owner operator. And we thought infractions might simply be due to a lack of training or awareness of infection risks. Similarly, thinking about why premises offering aesthetics may be more likely to be associated with a complaint or IPAC lapse. This might again be due to the broader range of services, meaning there's many different instruments commonly used, which are inherently sharp again and have the potential to accidentally penetrate the skin, although they're not intended to do so. And as Dave mentioned earlier, as body modification services such as tattooing and piercing deliberately penetrate the skin, these do require the use of sterile instruments and equipment. So although clients may expect some infection or irritation following the service, if everything's sterile to point of use, handled and discarded appropriately, the risk should be quite low, and any irritation or infection may be more likely to be due to aftercare and touching of the area after the service than to the actual service provision. So similarly, if anyone does experience infection or irritation following an invasive procedure, they may be more likely to just consider that part of normal healing and not actually view that as a trigger to report a complaint to the health unit. So hair and barbering tools most typically don't have the potential for cut or puncture, like hair rollers, combs, brushes. They're just not inherently sharp tools and don't really have the same risk associated with them. Even if they're not appropriately cleaned, they're lower risk. And then estheticians may also offer more invasive services and not be aware that they shouldn't be. So for example, I recently came across someone on a local mom group that I'm on Facebook who is proudly advertising that in addition to her pedicure services, which are permitted, they were also offering ingrown nail removal. I was like, whoa. And no idea that that wasn't something they should be doing because they weren't sterilizing, didn't have the ability to sterilize, no autoclave on site. And according to our PSS document that Dave mentioned earlier, there's actually a provision in there about PSS operators not to offer service on or near infected areas of the skin. So I think sometimes it's just a lack of awareness. So some food for thought. As we said, invasive services use sterile instruments and equipment, so it's kind of the highest level of prevention, whereas mani-pedi services and other aesthetic services do rely on reprocessing according to categorization of the instruments. And if there's a breakdown in the procedure where this isn't done at all or isn't done appropriately or following manufacturer instructions for the products, for example, then there is a potential risk for infection to occur if that accidental cut or puncture does occur. So there is that risk for potential infection if there's any errors during the procedure. So you could argue that given the prevalence of issues in PSS and in aesthetics in particular, maybe there's a case to be made to require sterilization in these premises, but I would say no, because this would be expensive. It would require a lot of education and oversight by health units. You could see why the temptation might be there to think go higher, and our best practice document does set the minimum standard. Operators are always free to go higher, but if so, they need to comply with the relevant requirements. So if someone does decide to sterilize, for example, there are a long list of expectations regarding documentation, et cetera, that they would then need to comply with. So I don't think that is necessarily the best solution. That has its own inherent issues. So there has been some discussion over the years. As Dave mentioned, we did used to follow a frequency-based approach in Ontario. When I was first practicing as a PHI, we did go into tattoo and piercing premises 3 times a year, aesthetics twice, hair and barbering once. And there's been some back and forth over the last few years about maybe we should go back to that type of model, but maybe that's not the best idea. So the million-dollar question is, how do we increase compliance? So we looked to the literature and we found that previous studies in Ontario have shown, for example, that increasing the frequency of inspection in food premises did not actually increase compliance. Similarly, a study of healthcare workers found that attitude and perception of risk were the most important factors in increasing compliance with IPAC practices. And a study of healthcare workers in Quebec that was conducted recently found that IPAC practices were influenced by premise culture. So putting all of the lessons learned together from other settings and other premise types, how do we create a culture of compliance in PSS? And in an ideal world, assuming that we can create that type of culture and increase compliance for routine inspections, how do we prevent lapses in these premises? So looking at some of the lessons learned in the literature from other premise types, such as healthcare settings, they recommended identifying barriers to compliance, that these can be individually addressed. So our takeaway from this is that a blanket approach might not necessarily be the best approach. And maybe it might be more effective if individual inspectors work with individual premises to identify their specific barriers so that these can be addressed and removed. So some of the things that we thought of might include factors such as time between clients, their cleaning and disinfection processes, or potentially language barriers. And so some strategies to address these might be spreading out appointments so that there's additional time built in for cleaning and disinfection practices to occur properly. Maybe trying to address some of the language barriers through specific provision of resources tailored to whatever language is prevalent in the particular area. And then maybe doing something like dedicating a particular staff member to cleaning and disinfection and rotating that role. So whatever the barrier is, trying to find a way to address it. Or maybe it's something like just changing up the disinfection processes and picking a product with a shorter contact time. I know going into PSSs in my inspection area previously, I did find premises that were using something with a 20 to 30 minute contact time, which is just not really practical. So one of the things we've thought about over the years is it would be helpful if we could develop alternate language resources for PSS. Our document that Dave mentioned is available in both French and English, but as our primary audience at PHO is the public health units and not the frontline operators, we're a little bit constrained in the variety of languages that we can produce resources in. So that's something that we'd have to work with the health units. So what were our conclusions? Putting all of this together. So infractions from routine inspections and from IPAC lapses were similar. So it does stand to reason that anything we can do to increase compliance and reduce infractions could theoretically minimize the risk and potential for a lapse to occur in these settings. And premises offering aesthetics, and particularly those offering nail services, were the most likely to have infractions identified. So working with these premises in particular to identify and address specific barriers to compliance might be helpful. And as the most common infraction was the reuse of reusable instruments without reprocessing and failure to discard of single-use items, improper use of disinfectants was also a common one. If you're wondering where to have a starting point or where to initiate conversations with operators, these might be initial areas of focus that would be worthwhile for you to look at. So we tried to come up with some recommendations based on our observations. So ours would potentially be to place an emphasis on operator education and identifying individual barriers to compliance, and then working with operators one-to-one to address these rather than focusing on a blanket approach. You could consider an alternate inspection frequency. However, if you do, this should ideally be based on consideration of factors such as the range and type of services offered, not necessarily the service invasiveness, because our data doesn't show that that's where the issues lie. As well as the premise compliance history of complaints, and then just the general operator awareness of IPAC best practices and willingness to work towards improving these deficiencies, which takes you back to that IPAC culture. And lastly, it would be helpful, particularly for premises that have multiple locations across one or more health unit jurisdictions, and for individuals such as ourselves involved in data surveillance and analysis, if health units were able to have access to or develop standardized inspection templates and premise categorization and frequency of inspection algorithms so that everyone's doing things the same way, and improve consistency across health units could also make it easier for operator compliance. I know one of the major gripes that I used to hear going into some of my premises, well, you ask for X, Y, and Z, but next door in neighboring region, they ask for ABC. Why don't you guys get on the same page? It's like, well, we try, but some of it comes down to interpretation. So what are we doing at PHO? Little teaser for you here. So Dave and I are currently developing a suite of service-specific resources for health units. And these are based on the common questions that we receive from health units and the services where we feel there could be some benefit in providing additional information to bridge the gap between what's in the best practices and what we know the issues are or questions that are arising from the field. So there's a snapshot of one of them, microblading, where we're focusing on a specific service. We've developed a few of these and hopefully these will be out soon. So that's a little teaser for you that we do have those in the works, but if you have any suggestions for those where you'd like to see one of those, we're always open to suggestions. We do respond to technical inquiries and requests for information from health units, and typically those are associated with specific services or specific pieces of equipment. So for example, we've gotten a lot of questions about the pen style tattoo machines over the last couple of years. So there's some certain pieces of equipment that seem to come up more frequently for technical assistance than others. We do assist health units with lapses. We participate in provincial and national working groups, including those that are run by a Sci-Fi, which I find really helpful. So in some of these calls, for example, we'll hear about a new service that our colleagues in Alberta, for example, have noted. And it's really helpful to know that because invariably whatever is found or pops up in one province very quickly pops up everywhere else. So it's nice to be able to share information and literature and research such as this, so that we're all kind of on the same page. And as Dave mentioned, we are planning to do kind of a post-analysis to examine trends post-implementation of the PSS Reg and to the updated guide to IPAC, which is more principles-based rather than service-specific, but we will still have that service-specific aspect through this suite of fact sheets, as I mentioned. So we were asked to also mention, in case anyone on the call is interested in doing the same type of analysis with your local data, or some similar analyses of your own, to go into a little bit of our lessons learned in conducting this work. So we thought we'd just highlight some of the challenges that we faced with this. So some health units, as I mentioned, do make routine inspection data publicly available by online data repositories where you can just grab it, download it, and work with it. Others don't. And for some health units, when we approached them to obtain data for the study, there were varying degrees of willingness to share data in order for us to do this work. Data is not always complete. So for example, for one health unit, when we started looking at the data, the database only had those inspections that had one or more infractions identified. So we had to go back and say, oh, we just realized every inspection here was non-compliant. Pretty sure some of them would have passed. And we had to get the compliant data set and merge those together. Service categorization does vary by health units. Some again are bucketed together versus separated out. And question wording, when we look at the questionnaires, also varies by health units. So that's why we had to do a little bit of card sorting, and we weren't able to get as detailed as we would have liked to be when we looked at individual infractions. So we did end up with those 16 thematic areas. Some health units, as Dave mentioned, do inspect certain premise types at differing frequencies. That used to be the blanket approach, and now it's kind of health unit by health unit. And as we saw in our poll, if it's a once a year versus varies by premise type approach. And one of the things we noted was the trigger for an IPAC lapse posting does appear to vary. So I think 15 of the health units that we looked at had none listed. And then for those that did, there seemed to be a little bit of a range in whether they were only posting those that resulted in public notification versus any lapse that was identified. So there does seem to be a little bit of difference there. So just to highlight, our publication is available if anyone has already read it. Thank you, we appreciate it. And to echo Dave, we appreciate you joining us to kind of let us showcase our work to a broader audience. It was really interesting. We've just kind of given you a snapshot of what we looked at. So I've provided the link and the reference if you're interested to learn more. And we had 2 more poll questions for you, if you don't mind answering those. If you can pull those up, please, Anna.
Sure. We just to let you know, we have 5 minutes left, but we can pull that up.
Okay, we'll just do one and then we'll go to our questions.
Okay, there it is. And you could type your answers in the chat box as well. And it
Thank
looks
you.
like we
So
do
then-
have a couple questions. Yeah.
Awesome. Okay, so the main thing we were really wondering is if you find this helpful, were our findings of interest, and how would you possibly anticipate, if at all, using the information that we presented to you today? Like, do you anticipate revisiting how you conduct your inspections, or the frequency, or maybe an alternate approach, or kind of food for thought? We're just hoping to know what direction this might take you in and how we might pursue future work. So that's just really to help us. So thank you very much.